morphine. But early, and there was a ton of other physicians that tried to use it to stay up when they needed to stay up for their hours. And so the prevalence of impaired physicians was almost 40% in some surveys. Methamphetamines has an interesting history and timeline. It was first synthesized in the late 1880s, and it was used commercially in World War II to keep soldiers awake because it lasted for a long time. It wasn't listed as illicit until around the 1970s when it was considered Schedule II under the Controlled Substances Act. And then in the 1990s, there became the internet, and then recipes started to become accessible, and meth labs started to occur. And that's how we are accustomed to familiarizing ourselves with meth at this point. It's much more common in the West and the Midwest, although there is a lot of meth use around here in central Pennsylvania and Appalachia. It's associated with risky sex, and so a lot of HIV transmission in men who have sex with men occurs in the context of meth use. It's oral, smoked, or injected. It's considered very neurotoxic, more so than other stimulants. So what we mean by that is evidence of psychotic symptoms can be more pronounced with methamphetamine use. But there are also other physical and psychological adverse effects. Cocaine comes from the leaves of the coca plant, and it's often mixed with additives. Lately, it has been seen to be mixed with fentanyl and amphetamines. Methamphetamines can also be mixed with fentanyl, and we've seen that as well locally. It can be snorted, injected, or smoked, and it can cause lots of things. And it can facilitate the transmission of HIV or hepatitis, specifically if it's injected. So how do the prescription stimulants work by contrast? So the most common are Adderall, or which are mixed amphetamine salts, methylphenidate, which is the active ingredient in Ritalin, and these work slightly differently. So the amphetamine salts work in the way that I had showed before in that cartoon, where it encourages the increased production of dopamine, whereas methylphenidate blocks dopamine reuptake, a little more similar to cocaine. These are very effective treatments for ADHD and treatment-resistant depression. So sometimes it's also used in the elderly when they show signs of psychomotor retardation. In other words, they're very not interactive. Sometimes a little amphetamines can get them to be more interactive as part of geriatric depression in the hospital or in nursing homes. And then they have extended release formulations that have less abuse potential and slower absorption. There are also milder stimulants. So bupropion, which is a common antidepressant, it acts on norepinephrine and dopamine release very mildly by contrast. There's little euphoria. It is rarely abused, but it is possible for it to be abused. I have seen that patients have injected it on occasion, and it is mildly energizing. And then there's also Modafinil, which is FDA approved for the treatment of sleep apnea and narcolepsy. And it is also used off-label for ADHD, chronic fatigue, and depression. So what is the problem? What is its prevalence in the United States? About 1.6 million Americans over the age of 12 have current cocaine use, and about 500,000 have current methamphetamine use. An additional 1.2 million report current non-medical use of prescription stimulants, And this prevalence has remained stable over the past 10 years. So there hasn't been a wild increase or decrease over the past 10 years, but prior to that, there was a big increase in the prescribing of amphetamines for ADHD as more and more people started to screen for it and screen positive for it. And so why do we talk about it at all in general? Well, a lot of it has to do with deaths. And unfortunately, with the advent of synthetic opioids being widely used illicitly, we've seen that amphetamines and cocaine increasingly have been cut with fentanyl and can lead to overdose deaths. So this is national drug overdose deaths with psychostimulants from over the past 18 years. And some of these include the combination of any opioids, psychostimulants alone, and psychostimulants and other synthetic narcotics. So you can see how the synthetic narcotics, including fentanyl, have led to a recent rise, but psychostimulants without any opioids is also causing overdose deaths as well. And chronic use has health consequences. So it can cause cardiovascular disease. It can lead to premature aging in cardiovascular disease. It can lead to malnutrition. You know, there's no diet quite like the cocaine diet, and it can lead to miscarriage and pregnancy. There's also increased risk of cigarette smoking and all that comes from it. Psychiatric disorders. People become psychotic on these meds. And also the acquiring and transmission of STIs. This is really critically important because people lose their inhibitions and they start engaging in riskier sex. So I'm going to start reviewing what the current treatment evidence is out there for stimulant use disorders. And I'm going to start with what doesn't work. So it is a long list of what doesn't work, but a lot has been combed over. So in terms of randomized controlled trials, the following classes of drugs have all been looked at. Pharmacologic and non-pharmacologic methods have shown no benefit versus placebo. So antidepressants don't work, anticonvulsants don't work, antipsychotics don't work, and MEOIs don't work, and acupuncture doesn't work. And these are when it's tried just one drug, so one medication, versus nothing at all. So this is not combination medicine. And so here are a few examples. So this is a number of studies that look at whether bupropion, which is the mild stimulant, can help with cocaine use disorders. And this looked at 4 studies with a total number of people treating about, looks like a little less than 100 people looked at. And so they find that that the placebo actually worked better than the antidepressant here. So that's not good. That's a negative outcome. They looked at topiramate, which is an anticonvulsive medicine, to see if it can help with cocaine abstinence. And it's a mixed bag. There's one study that looked at actually a combination of 4 different studies and found that while it looks maybe slightly promising in the Topamax category, the summation diamond crosses the line, which means that that could also be due to random chance. This 2 set of studies that are done by the same lab does prove potentially positive for topiramate, that topiramate is helpful. But these last 2 studies show that there was absolutely no difference. So very, very much on the fence whether topiramate works. Aripiprazole is an antipsychotic and a very interesting medicine because it kind of works in the same way biochemically as theoretically Suboxone does. So we all know Suboxone in the treatment of opioid use disorder. That's buprenorphine is the active ingredient. And the way buprenorphine works is it is a partial agonist antagonist at the opioid receptor. So it activates the opioid receptor, but it also blocks other opioids. And it works very well. It's very effective in the treatment of opioid use disorder. Aripiprazole, if we go over to the dopamine receptor, is very similar. So it is an agonist antagonist of the dopamine receptor. In other words, it will activate the dopamine receptor, but it will block other dopamine agonists. So you think, perfect, this is just what we need for stimulant use disorder. Unfortunately, didn't work. It was a big negative. In fact, people just compensated with the perceived blocking of cocaine on the receptor by using more cocaine. This is a summary of any psychotic and any antipsychotic, I should say. So the way antipsychotics work is they are complete dopamine blockers. So they block dopamine in the brain and they don't let anything, attack it. And similarly to aripiprazole, people compensated for this by using more cocaine. So it didn't really work. So then they looked at these medications for its efficacy in methamphetamine use disorder. Maybe there is a chemical difference, even though there's no clinical difference between the amphetamines and cocaine. So maybe there would be a different outcome. But they looked at bupropion and methamphetamines and found that with mild use of methamphetamines, that bupropion had some efficacy. Maybe it would work, but only in mild use patients, and that's very ill-defined. But overall, it really showed no difference. So now I'm going to move into the category of needs to be studied more in terms of stimulant use disorder treatment. So there's insufficient evidence, but maybe we can see some promise with cognitive behavioral therapy, antabuse or disulfiram, using prescribed stimulants to treat stimulant use disorders. Perhaps the use of opioid agonists, buprenorphine, could help. And a medication called N-acetylcysteine, which is a medication that's actually used in the treatment of acetaminophen overdose. So very interesting thoughts. So right now, it's insufficient evidence that these treatments work. So now I'm going to move into what works. And let's see. Can everybody still hear me? My view has changed. I just want to make sure that I'm still talking and everybody can hear me.
Dr. Kawasaki, we can still hear you and we can still see the screen.
Okay, great. Great. Okay, excellent. So, so here, this is a controversial approach, but with different studies, it has shown that there is a subset of people with stimulant use disorders who are self-medicating for actual ADHD, and with ADHD, there is a very common prevalence. About 1 in 5 will have substance use disorder. Sorry, the other way around. So in people with substance use disorder, 20% will have ADHD. But it's really important to establish that this is a real diagnosis. And in order to do that, you have to take a detailed history about how their childhood was and how elementary school was for them. And in this particular subset, The stimulants, prescription stimulants, consistently have displayed efficacy for abstinence of illicit stimulant use disorder. It is met with resistance in the treatment field because of the abuse liability. They're worried that it will lead to abuse of these prescriptions. But among patients who were also receiving methadone for opioid use disorders, methylphenidate or extended release Ritalin was safe and not associated with misuse. It didn't, however, show any benefit to cocaine abstinence, but in terms of the abuse liability of the prescription, that did not bear fruit, and it was found, in fact, to be safe in that population. And then overwhelmingly, what is the really the mainstay of treatment for stimulant use disorders is something called contingency management. Now, what is contingency management? So it works on the theory that drug use is an operant behavior. In other words, we can reward you positively for doing the right thing, or we can punish you for doing the wrong thing. And that punishment will lead to a decrease in the negative behavior. So it is also a non-drug alternative reward. And reward is really the important word here, because we want to go back to how the brain produces dopamine and how we can actually get the brain to produce more dopamine so that people can stop having a need for using stimulants. And it's found that success rates of abstinence are about 50% higher in individuals that engage in contingency management use. And it's basically an exchange for small amounts of money. So essentially, you're paying folks to not use stimulants. But it's not as simple as just getting, a gift card a week, right? It's a whole process. And I'll take you through one example of how contingency management was done at one study. It's really effective at treatment retention and abstinence. And it works with all stimulant use disorders. It also works in alcohol use disorder. But this is a behavior modification. So to go back to this slide, games and food cause a dopamine surge. So it's something that can actually be helpful. Now, it's obviously never going to get you to meth levels of helpful, but it is something while the brain is healing to keep these folks going so that they can, have longer and longer periods of abstinence and their brain can continue to heal. So this is an example, this is a published example of how contingency management was done at one clinic. And so it was a multi-site study that looked at 113 individuals. And it was done in this very particular way. So at the initial screening, which is often about 30 minutes to 40 minutes, everybody got $20 just for doing the initial screening. And then after that, they were randomized to treatment as usual, which would be therapy, including matrix model, cognitive behavioral therapy, and relapse prevention, versus treatment as usual plus contingency management. And it was a 12-week assessment, and also all sites encouraged 12-step groups. So at the end of each week of the 12 weeks, everybody would get a urine drug screen. Those who tested negative for amphetamines or methamphetamines could draw between 1 and 2 chips from a container with 500 chips. Now, the 500 chips were divided as follows. About half of these chips just had affirmations on them, saying, good job, great work, way to go, kinds of stuff. About 40% had small prizes in the range of $1 to $5 that could get them, these could be toiletries, snacks, bus tokens that were then sort of kept in a supply closet. 8% of the chips were large, $20 gifts that could be kitchen utensils, toys, or gift cards. And then 0.2% were these jumbo gifts, including 80 to 100 bucks, which at the time was DVD players. Now that's less, useful. Stereos as well. There was a TV in there too. So each week that you would get that a patient has with negative urines allows you more draws. So the more weeks you accumulate that you're sober, you would allow more chances to draw out of the bowl. And the draws decreased if you had any unscheduled absences. So again, this goes by operant behavior. If you are punished by a negative behavior, you're less likely to do that. And so the first 2 consecutive weeks of sobriety, everybody gets a large prize. This is also really important, that everybody is sort of rewarded with a $20 reward right away. And then people get really excited moving forward. The maximum amount of draws that any one individual was allowed is 204 draws and $400 in prizes max per person. And so, so this is really important. The reason why I'm describing this in detail is that if you're thinking about using contingency management for your program, you will have to budget for it. And this is kind of what the budget looks like. So this was the outcome of doing this setup. In terms of retention, there was no significant difference between the folks that got contingency management and the folks that didn't, but there were significant differences in negative urine drug screens, and there was a longer mean period of continuous abstinence. So, so this is really important because you want the brain to start to heal. And how are you going to get the brain to heal if you aren't rewarding for it? And so this study only looked at 12 weeks, but if you were to extend it out for longer, how long would that be necessary? So future studies, this is what is the hot topics across the country and at the National Institutes of Drug Abuse that people are interested in and are interested in funding for the future. So the big moves right now are combining medicines. So when you can combine 2 medicines at lower doses, it may reduce stimulant use and also eliminate the risk of increased side effects from higher doses. So we saw that there was ambivalent mixed results with topiramate, but combining that with low-dose amphetamines, prescription stimulants, may be a really great option. Naltrexone, the opioid blocker, is also getting an increased look. And also treatments that also concurrently treat obesity, cigarette smoking, and ADHD are what is lying behind the latest interest. So there has already been legwork done looking at combining medicines. And with cocaine use in particular, they've tried all these different combination meds, some of which are beta blockers, some of which are old antidepressants, some are amino acids, and benzodiazepines, which are problematic. But the combination of amphetamine and topiramate actually did show some promise, and so that's getting further increased look. And you have to be careful about what you're using because sometimes you can increase cocaine use. For methamphetamines, a couple of different prospects loom, but one is using alprazolam, which is problematic, and another is less problematic, but flumazenil is an interesting choice. That's actually GABA receptor antagonist, and it theoretically is used in the treatment of benzodiazepine overdose, but it's actually not used because it can cause seizures. So for that reason, this combination is a little problematic as well. But people are very interested in looking at the combination of naltrexone, bupropion, and mirtazapine. Mirtazapine is another antidepressant, and to see what's going on there. I should note that naltrexone and bupropion are currently approved in a medication to treat obesity and to treat compulsive eating. So to sum up, most medications have failed studies. This is really, stimulant use disorder is a tough topic because, you know, we wish we had more medicines to treat this, but we don't. And so we need to look at the combination of meds, and we really need to study these closely. But what has been shown to really help people stay off stimulants for longer is contingency management. That is harder to pull off without a budget. And so you need a budget and funds received in order to do it. And the studies look at 12 weeks, but it's probably clear that you might need longer. How much longer really depends, and that is something worth studying. You know, where does it all end? Maybe it ends when, you know, the individual gets a job and they find that, you know, hey, they can actually get paid for working, and that also gives them a dopamine kick. So you know, but those questions do still need to be answered. They are going to look at combination medicines such as amphetamines and topiramate, also naltrexone, bupropion, and mirtazapine. And there are ongoing trials that are also looking at off-label and combination medicines. And that's all I have. So ending a little bit early, but would love to start a discussion. I know that there was a question posed that's looking at why contingency management is not more widely used. And I think people are largely responding that it's expensive. And it is, potentially is. But I think that if you can put a dollar amount to what you need, which you can, based on what was done in 2006, and that was 14 years ago. So you might want to increase the prices a little bit. Even the Tooth Fairy is reimbursing more these days than in 2006. But you can certainly come up with the number of patients that you plan on treating, the dollar amount per patient, and figure out what funds may be available for that, either through development outreach to get donors involved, or to figure out where to get external funding.
Thank you, Dr. Kawasaki. That was an excellent presentation. Yes, we are open right now for some questions, and I do see that some individuals have posed some questions in the chat box. So there's a first one here. Jim asked, he stated that there are limits on the amount of monetary rewards.
Yeah, so I mean,
so
I would say
$400
that if
exceeds
you're
that
limited,
limit. Thank you, Jim, for
with a
bringing that
max
up. Dr.
dollar amount you're
Kawasaki, I don't know
allowed
if
to
you
give
have anything you want
patients,
to
then
add to
that's what you
that.
budget for. You know, I still think something's better than nothing. And what was done under those experimental conditions don't necessarily need to be done in real world conditions, especially if it exceeds the amount you're allowed to give patients. Yeah, it's not good.
And then we had
I
another
think that
question about what is the
once the
abstinence rate
12
once
weeks
the
of
12
treatment
weeks of
ended,
contingency management
people went
ends?
back to their old behaviors. I will say though that they're pretty. So that famously, images done of the cocaine addicted brain showed deficits that didn't resolve until about a year and a half of abstinence. Now, that's not to say you need to budget for a year and a half of contingency management planning, but I think it's fair to say that 12 weeks is probably not long enough, and you would want to develop some sort of ongoing reward. Now, to go back to Jim's question about monetary reward, sometimes you can bypass that by not giving them actual money. So some of these individuals were gifted objects, instead of like not gift cards, but things like toiletries or kitchen utensils. And so therefore they could sort of bypass the monetary limits. Um, but um, but yeah, how do you do this? I think that if we have the evidence for it, certainly finding out what's permissible within your organization is worth an investigation.
Okay, and then Kim
These
asked,
are
are
done in
these methods
outpatient
being used in
programs.
treatment
So it's not
programs,
only done in
inpatient,
research
outpatient
settings,
settings, or only
um,
being studied
but
in a
these are
research
routinely
setting?
done in outpatient programs.
So if you have any additional questions, you can definitely type those into the chat box, and we can certainly answer those because we have some time left. Dr. Kawasaki, I was wondering if you could speak a
Yeah,
little bit
so I
about
would
just
say
kind
it
of the
probably
withdrawal
takes,
from stimulant use disorder
obviously
and what
it's
that
dose
looks like and some
dependent. It depends
considerations for that.
on how much a patient was using, whether it was a daily habit, for how long they've been using. But I would say anywhere between a week and 6 weeks, you would get a syndrome of melancholy, depression, feeling a little blurry, vague, and um, and in general just flat overall. Um, so that is typically the clinical presentation of withdrawal, but it's not a physical withdrawal. It doesn't manifest quite like alcohol withdrawal or opioid withdrawal. It is much more of a psychological uh, picture, and so that is what you'll see. Now there is actual dopamine depletion in the brain causing this psychological picture, but that's what you see. So a lot of folks will ask for antidepressants because they are feeling depressed, but that's actually not an accurate diagnosis that you can make until there's really a 4 to 6 week washout period. Now, that's not to say that you can't start antidepressants before the end of that, but it just may not be what they need. Specifically, if they're using stimulants, you want to make sure that they don't have an underlying mania or hypomania that starting antidepressants for might end up doing harm.
Thank you. So we have some really good questions coming in here. Dina
So
asked,
a
does it need
lot
to be
of
money that
what the
people
chips
receive,
in the
or are there other
jar
incentives that
like
can be
say,
offered that are
actually
effective?
most of the chips are just positive affirmations. So something that you could think about is how to celebrate a patient or celebrate their small wins um, to help them, which is not financial, right? There can also be, you can think of things like ceremonies for patients that are doing well that week, or um, you know, uh, highlighting art that they may draw, or have them speak at a group, or do something to reward them, even if it's not a physical reward. And I think you can individualize it to what a patient is interested in. If they're an artist, or if they're a musician, or like to talk, anything like that, or write.
Great.
That's a
Connie
great
asked, are there concerns
question.
about how contingency management and the use of
So
drawing
I
tokens
don't,
closely relates to
it is
gambling?
not well documented in the literature that stimulant use disorder and gambling disorders are related. It is not well documented. As well, the treatments for the two of them are different. So sometimes people who are on stimulants can develop gambling use disorders, but that is different than somebody with a primary stimulant use disorder. And I have not seen in the literature whether there is this risk of gambling with the use of contingency management. It is more likely that somebody is going to develop a gambling disorder while they're on stimulants than while they are not. But that's a great question.
So Laura asked a very similar question.
Not that I
Basically,
have
have there been any
seen.
studies with individuals that
I
have
know
gambling
that for
issues along with
gambling,
substance use disorder and
the
contingency management?
mainstay is cognitive behavioral therapy, and sometimes gabapentin is used. So it is different. And so I'm pretty sure that those folks are kept out of the contingency management game.
Okay. Nancy asked, are they combining other substance use disorders with the stimulant use disorder group in group settings utilizing contingency management? Does everybody
Yeah,
receive
so
monetary rewards?
these
Again, kind of
studies have
spoke to
also
this
been looked
earlier,
at
but
people
maybe you
with
can
both
speak to the
stimulant and
combining
alcohol
other
use
SUDs
disorders,
with the stimulant use
and
disorder
shown
group.
to be both very effective. So if people do have polysubstance use disorders, contingency management can work. What works best are these rewards, either financial or in these gifts. Ooh, does caffeine
Natalie asked, where does
release
caffeine fall in the
dopamine?
stimulant spectrum? The graph of
Um,
food, sex, etc.
I am unaware of how caffeine works on the dopamine receptors. That is something I will actively Google. But I think that's tricky. I think it depends. Like if you're taking a caffeine pill, that might look different than when you're drinking coffee, because you're drinking something that arguably has a pleasing taste to some people, which also releases dopamine. So I'd have to look. I think, energy drinks can cause a psychosis if that's all you're drinking, and certainly too much caffeine can do the same thing. Um, and that may be a combination of the direct stimulant effects from the caffeine itself, versus the lack of sleep that builds over time from overuse. Um, but that is something I'm going to have to look up. Yeah, so
and Kim asked, can you address the prevalence of use among gay men?
Who is using it really varies in geographic location in the country. Depending on where you are, men who have sex with men, there is a wide prevalence of methamphetamine use. But there may not be that may not be the case in areas where there isn't a big identified men who have sex with men in the area. So that's a roundabout way of answering the question. If there are large gay communities in different urban settings, there is going to be a subset of methamphetamine users relating to high-risk behaviors in that community. But without that, in more rural areas, it is less likely to be associated with methamphetamine.
Thank you. Scott asked if we pay for those who are struggling with stimulant use and clients with other use disorders find out as they inevitably will, how do we respond to them when they expect a payout as well?
So I think
without
that
disenfranchising them.
There always needs to be expectation settings from the outset. That you have to explain how contingency management works, and that they aren't going to get a payout every time they participate, and that some of it, it's basically it's chance, but it's what they do, and that's sort of the best you can do in terms of managing expectations. But encourage them that they should expect, overall over the course of the contingency management period, they should expect rewards. And but it's also a part of the counseling that rewards aren't necessarily always financial.
And then this looks like the last question we have in the box here. Rachel asked, similar to the caffeine question, do you know if nicotine releases dopamine in the brain?
But that is an indirect method of dopamine release. So opioids release dopamine in the brain as well. Dopamine is the reinforcing hormone. So it is the neurotransmitter that causes somebody to do it again and again and to build the connection that can cause addiction. So any sort of reinforcing experience, in other words, a pleasurable experience that you get from smoking will produce dopamine. And that was in smoking, I believe, is a part of the chart. Maybe not. Hold on. No, it was not. Never mind. So for example, when you take an opioid, that inhibits the release of one neurotransmitter, which ends up releasing dopamine indirectly. And I think that's what also happens with the nicotine receptor getting activated. So it's not a direct dopamine release, but it's definitely an indirect one.
All right. I think that is it for, let me just make sure we're not missing another question here. I think we're okay. It is about 11:55, so if anybody wants to type in another question, we have time to do that. Otherwise, I want to say thank you to everybody who participated today. These were some very wonderful questions, great discussion. I want to say thank you so much to Dr. Sarah Sharfstein-Kawasaki for presenting today on this really important and interesting topic.
Yeah. Sure.
And somebody did
Yeah, that's
ask if we
fine
were
with
going to be
me.
providing the slides after the presentation. I do not know the answer to that, but it looks like Dr. Kawasaki is shaking her head yes. Um, so we will certainly,
No, just thank you so much for
great, we will
having me.
certainly be
It
sure
was
to
a
get those
delight to
out
speak
to
to all of
the
you.
participants as well. Dr. Kawasaki, any last thoughts that you want to say?
Bye-bye.
Wonderful. Thank you so much again, everybody. Have a great rest of the conference and stay safe.